Welcome to this IPA webinar. It's my pleasure to invite you to listen with us to a webinar on social isolation and loneliness and later life, a clinical approach. The webinar is organized by the IPA, and the IPA is an organization dedicated to mental health of older people. It's the world-leading multidisciplinary global psychogeriatric association. We are the task force webinar series, and I organize this together with my colleagues, Professor Maria Lapid from the Mayo Clinics and Dr. Rob Medan from Toronto. I am Myrra Vernooij. I'm a professor at the Radboud University Medical Center in the Netherlands. And I do have a special interest in social health and dementia research. And in fact, loneliness is an important social health marker. We are happy to have today's speakers. Dr. David Conn, Professor David Conn, and Professor Diego de Leo. Before they start, I want to say something on the webinar series. It originated during COVID, and our format is to have an integrated dual presentation. We deal with one theme in depth, and we cherish the discussions, and so do you, like we see in our evaluation. I would like to ask you to think about questions and to put your questions in the chat. Is loneliness in older adults, and loneliness is a growing concern that can significantly affect mental and physical well-being. Is a very important topic. The first speaker will tell us more about it, and the first speaker is Professor David Conn. He is a professor at the Department of Psychiatry at the University in Toronto, and he is a geriatric psychiatrist at Baycrest Center. Professor Conn is a founding co-chair of the Canadian Coalition for Seniors Mental Health. He received numerous awards. Among them is the IPA Medal for Distinguished Service Award. The floor is yours, David.
Thank you so much, Myrra, and I want to thank the organizing committee and the IPA for allowing me to speak today, and also my partner today, Professor De Leo. It's an honor to present with you. We're going to be talking, of course, about this important topic, and I don't have any disclosures to make. Just to note that the work I'm going to be talking about has been funded by the Waltons Trust, Canada. Some learning objectives, hoping that by the end of the presentation, you'll be able to list risk factors and negative health impacts associated with social isolation and loneliness, be aware of the main recommendations from our new clinical guidelines, and to reflect really on factors that contribute to this and recommend appropriate interventions for your patients. CCSMH, Canadian Coalition for Seniors Mental Health, has been around for about 20 years. And one of the main things we do is create clinical guidelines. So if you are interested, you could get these guidelines and others from the website there, ccsmh.ca. I'll move pretty quickly today, but if you're interested in a copy of these slides, just email me. I'll put up my email at the end. So just for the point of definition, I think it's important because we talk about these two things as though they're the same, but they're not. One's objective, one's subjective. So social isolation is a measurable deficiency in the number of social relationships that a person has. You can measure it. Whereas loneliness is an internal subjective experience, unpleasant sensation. It's felt when a person's social relationships are lacking in quality or quantity compared to what they desire. And they often go together, but not always. So more social contact does not automatically reduce loneliness. So it's an emerging geriatric giant, as we would call it. So many countries have declared this as a very important issue. The United Kingdom really got off to an early start. They created a campaign to end loneliness in 2010 and actually appointed a government minister of loneliness in 2018. And then other countries have also declared national strategies like Australia, Japan, Netherlands, USA. One could ask, are these effective? I'd be interested in your thoughts about this during the discussion period. WHO also recently named it a critical issue and launched a commission on social connection. It was Mother Teresa who said that the most terrible poverty is loneliness and the feeling of being unloved. And the Surgeon General of the United States, Vivek Murthy, said, we live in the most technologically connected age in the history of civilization, and yet rates of loneliness have doubled since the 1980s. This is data from Canada. It basically shows that rates of loneliness increased dramatically during the pandemic, so no big surprise there. And clearly this is an issue that's grown in importance through the pandemic, where we all experienced some degree of isolation and loneliness. Women more than men, the rates of increase was greater in women than men. So Frieda Fromm-Reichmann, German-American psychiatrist, in 1959 noted a strange reluctance on the part of psychiatrists to seek scientific clarification of the subject. She said it comes about that loneliness is one of the least satisfactorily conceptualized psychological phenomena, not even mentioned in most psychiatric textbooks. She said it seems to be such a painful, frightening experience that people will do practically everything to avoid it. So a quiz question, is loneliness included as a criterion for any mental disorder in the DSM-5 TR? It's used, of course, in North America. And what's the answer? Well, be interested to hear, is this a trick question? Here's the answer. So it's only mentioned once in 1,000 pages of the DSM. It's a criteria within prolonged grief disorder, which makes sense, of course, but surely it should be mentioned more than once. And should there be a loneliness disorder? Is it a disease? Question to think about. And then when we think about the impact, the associations of social isolation and loneliness, what you see here is dramatic increases in a whole variety of physical illnesses, dementia, functional decline, death, and then, of course, depression, anxiety, strongly associated with isolation and loneliness. And this is from the New England Journal of Medicine, early last year. And Lundstedt and Perissinotto say that social isolation and loneliness are rarely listed on death certificates, yet they may have contributed to the excess deaths from all causes observed during the pandemic. And although the health sector cannot solve this problem alone, the medical community does need to respond. Clinicians will require adequate training, resources, and support to integrate screening, interventions, and referrals for social isolation and loneliness into their existing responsibilities. They conclude by saying, patients' lives may hang in the balance. Well, that's a pretty dramatic statement that was published in the New England Journal. So here in Canada, we thought this is, yes, a serious problem. What do clinicians actually do about this? And we decided to develop clinical guidelines, evidence-based guidelines, with the primary target being healthcare and social service professionals. And we set about doing this in a couple of years ago. This was the group from across Canada with a multi-professional, multidisciplinary group with some clinicians and academics, excellent group that worked on this with some other colleagues listed here. And we also did surveys with older adults and professionals themselves as we were working on this. We used sort of classic guideline methodology, the GRADE approach, and so on. Some of our recommendations, though, are consensus-based, meaning there really isn't a lot of research to support the recommendations. We did all of the things you usually do, a big literature review. One of the big findings was that actually we couldn't identify any existing clinical guidelines from anywhere in the world, which we thought was interesting, and we wondered why. And I think one reason might be that loneliness hasn't been considered to be an illness. It's a social health problem, but as we can see, it's a health problem. One of the members of our committee had, during the course of our work, had published this, done a meta-analysis and systematic review of this problem related to older adults. So their data was extremely helpful, of course, as we developed the guidelines. We've recently published in Geriatrics a sort of brief review of these guidelines and a second paper looking at the limitations of current literature. So I'll go over our main recommendations, which can be fit into these 4 categories. The first is that as professionals, we should have a knowledge of the major risk factors for social isolation and loneliness so that we can identify older adults who are at risk, maybe even anticipating that this could be a problem. And that could help us with actually preventing either the development or the worsening of social isolation and loneliness. So this was one of our main prevention recommendations. And here are some of the risk factors that you could guess probably, but there's a whole host of risk factors that put individuals at risk, including, of course, things like living alone or being a widow or divorced, being caregivers, low income, poverty or education, being in a minority group or disadvantaged group. None of these are surprising. But physical health issues, mental health issues, and so on are also critically important, as well as major life transitions. We recommend targeted screening. So that's that professionals should use targeted screening for those individuals who have risk factors. One thing to mention, though, is that there is a stigma issue. So some people may be less open to discussing this or for the fear of being labeled lonely. And there are screening tools that we recommend. There are many have been used mostly for research rather than clinical purposes. We also want to mention that, it's not just a matter of increasing social connection. There is a value to solitude as well. And so balance is important. Here's a list of some of the screening tools that we thought were important to include in our guidelines. Some focus more on loneliness, some focus more on isolation, some are short and some are long. A couple of the brief ones here, the single item loneliness, single question, that's attractive, but also the UCLA loneliness scale, which just has 3 questions that you can see there. Interesting. This is the loneliness scale, but it doesn't actually use the word lonely, you'll see in the questions. We recommend a thorough assessment, of course, and guidelines tend to, always be utopian, but it is important to figure out what are the causes. Why is this person isolated? Are there underlying health conditions that could be treated? So taking a biopsychosocial approach, we do recommend a comprehensive assessment that includes this whole variety of things that you would normally include in a full assessment. So again, this is ideal. We recognize, of course, that different health professionals may have different scopes of practice. And then when it comes to interventions, the overall approach is that, we need to recognize underlying conditions and treat those. We need to take an individualized approach with shared decision-making, understanding a person's interests to determine what interventions might be helpful for them, and to recognize the diversity within the older adult population. And so these are the different interventions, and we could not say, there's one intervention that's way better than another intervention. These are all interventions that may be helpful for some individuals. So an individualistic approach is really important. But yes, we should support, encourage, and empower individuals to engage at their optimal level of social activity, whatever that happens to be. One way of approaching this is called social prescribing, and a lot of countries are now investing in this, which is basically a way of connecting a patient with the community's resources. And often that's difficult because it's hard to know what all the resources are. And there are specific workers called link workers or system navigators who can actually help the person to make those connections in the community. So if one's fortunate enough to have a link worker in your community, then you can make a referral through that person. Otherwise, of course, as professionals, we can do everything we can to help the person find and encourage them to find the right resources. Physical activity, which we recommend, of course, for just about everything, but there is literature supporting the fact that increased physical activity can actually help loneliness and isolation. Naturally, of course, that would be best done in a group setting, but there's actually literature showing individual activity can also help. When it comes to psychological therapies, yes, there's evidence that a whole variety of psychotherapies, such as CBT, social cognitive therapy, reminiscence therapy, and mindfulness-based stress reduction, can be helpful. There seems to be more evidence that psychotherapies can be helpful for reducing loneliness per se, compared to isolation, but clearly they can be good for both.
Dr. Conn, your screen is not sharing any longer. I don't know if that was on purpose.
No. That is very strange. I don't know. Shall I stop sharing and re-share? It's very strange. Okay. I'll stop share and I will try and share again.
Okay.
Is that working now?
Yeah.
Okay, great. So animal-assisted therapies and ownership, some literature on this, and you know, owning a pet, having a dog walking around the community, people start talking to you. And the image over on the top right is from the Netherlands, where part of their loneliness campaign includes a program that links older people who can't afford or don't have the resources to have their own dog with a younger person who works and doesn't have time to take their dog for a walk. And it's been an incredibly successful program with thousands of matches made. And I think it's a beautiful example of the kind of things that can be done to help with this issue. We recommend leisure skill development and activities. We recommend, of course, technology, which we all found incredibly helpful during the pandemic and continue to use, such as right now. For older people, technology can be wonderful, but we have to recognize the limitations that some older people don't have the capacity, the digital literacy, or the resources. So actually helping people to become more tech savvy or to have the resources can be very, very helpful for people who find it really hard to get out of their homes. We don't recommend any particular medication to treat loneliness, although there's some literature out there that has suggested that it's possible. There's not enough evidence for this. But of course, if a person has an underlying illness such as depression, then we would, of course, recommend either psychotherapy or medication to treat that problem. Finally, we say, hey, you've found loneliness and isolation to be a problem. You're working with your patient. Make sure you follow up with them, do a reassessment in the short term, see if you can establish some goals or help them to establish some goals, and then meet with them again to see how they're doing. Our guidelines include some information about special populations, such as Indigenous older adults, residents of long-term care homes, and people living with dementia. And finally, this is from the United States. This is from their document on social connection. And it emphasizes that there are many different pillars which are required in order to really have an impact on society as a whole. And we need to take a really comprehensive approach to any sort of national campaign. So, you know, today we're talking really about pillar number 3, which is mobilizing the health sector. But there are whole other approaches that are really vital. I mean, really, including changing our culture and improving connection right across society at all ages. It's not just a problem for older adults. So key points, we are uniquely positioned to be an important part of the system for older adults at risk of or experiencing the health impacts of social isolation and loneliness. We should recognize the diversity within our populations, including incorporating culture and lived experience, taking an individualized approach with shared decision-making. We recommend targeted screening and a comprehensive assessment, and note that there are many different interventions that can help a person. We just got to find the best fit. Social isolation and loneliness are two unique experiences, but often connected, and we need more research to understand the differences and the overlap. I do note that we're fortunate to have some funding for a second phase of this project where we're going to try and implement the guidelines themselves. Here's a few documents from different countries highlighting this issue from Canada, United States, Britain, and the WHO. Again, I'm happy to share these slides. If just email me. That's my email, decon@baycrest.org. And I look forward to an engaging discussion with you after Professor DeLeo. Thank you. Oh, Myrra, you're on mute.
You're muted.
Yeah. Thank you for putting loneliness into the spotlights and for sharing the guidelines with us. I think you have a great audience here for implementation of your guidelines. And so thank you. And I will now introduce the next speaker. It's Dr. Leo DeLeo. He is an emeritus professor in psychiatry at Griffith University in Brisbane. And he is also the president of the Italian Association for Psychogeriatrics. And he is the promoter of a National Day Against Loneliness. He published over 500 peer-reviewed articles. And he is now speaking from Rodrigo, which is quite near Padua and Venice. Dr. Diego, the floor is yours.
Thank you, Myrra, and thank you all for listening. No disclosure from my side too. And there is an Italian Association of Psychogeriatric which counts approximately 850 members. We have an international journal, which is Geropsych, a bit of suggestion for buying. And we hold a national day for fighting loneliness, which is the 15th November each day. So it would be nice if we all cooperate to create a World Day for fighting loneliness, to end loneliness like the Britons. So this is the next Congress, which will be in Padua. What I give you is some highlight of the prevalence data, the pathways, the possible pathways into loneliness, and a few topics that are particularly concerned by the presence of loneliness and some conclusion. Now, as you can see from this table taken from the Generation and Gender Survey, there is no doubt that old age is particularly affected by loneliness, and particularly in females. These are data from UK, and on your right, you can see that 1 in 3 people aged 70 plus are affected seriously by loneliness. And the report from the British Red Cross and the Co-op counted over 9 million Britons suffering from loneliness. The estimate of loneliness following this meta-analysis and meta-review is that severe loneliness can be something around 27% of the over 80 people. So the advanced age is most affected by loneliness, and moderate loneliness could be around 32, similar to social isolation. And David already differentiated the concept of isolation and loneliness. These are very recent data from Italy, and again, the accent is in the over 85, who are particularly affected by loneliness, with 16% of Italians aged 65 and plus that have no contact at all with any people, any phone call during a week, a normal week, which is quite terrible if you think. And clearly, old age is the period in life in which you are dependent, you are very vulnerable. So you need family members, if you are lucky enough to have close to you family member, caregivers, or services from the public sector. And one of the most frightening event is the loss of your spouse, because it's very difficult to create a new project in your life and to have the resources and the support needed to counteract this terrible loss. But what are the main pathways into loneliness? Well, they are different from people to people, but in general, they can derive from early days, losses in among parents, in your absence of parents, neglect during infancy, or being abandoned by society, lacking a precise identity or the sense of belonging, etc. And one of the dangers is the stigma that ends by trivializing also the feeling of loneliness, which is terrible. And this is a slide from Carla Perissinotto, who is one of the main authors in the area of loneliness. And you can see that there are intrinsic and extrinsic factors. Is a good slide to have a schema of what could be the origin of this terrible feeling. But there are complications, of course, many complexities in working in this area, because you have different types of loneliness. We can have a continuing, long-standing loneliness, or an intermittent type of loneliness, or a loneliness that may evaporate. For example, when you enter voluntarily nursing homes, or changes after bereavement, or changing your financial situation, and you may adapt slowly and become less lonely or feeling less lonely. But what could be also the origin at the biological level? It could be increased inflammation. We talk a lot about neuroinflammaging. It could be the stress response. It could be the immune system function, which is impaired. And it could be also lack of activity, poor nutrition, sleep disorders, etc. A number of physical phenomena that may facilitate loneliness. But why loneliness has attracted so much attention during the last decades? Because of its recognized influences on the health of individuals. This is Louise Oakley, which has been a co-worker of John Cacioppo, another main author, Dr. Loneliness. This is the Nature, and Nature presents an article in which is clearly identified the impact on health, including premature mortality. But other conditions that are affected are particularly in the area of cognition, particularly in the area of dementia, particularly in the area of vascular disorder, and also, as is easy to imagine, able to provoke depression and suicide ideation. Let's talk a little bit about this main issue. This is a kind of seahorse that people in the area of dementia may have become familiar with. And now social isolation and loneliness have become a recognized factor for dementia, which had previously 12 recognized risk factors, to which 2 more were added. LDL and hypervision were the new factor, but social isolation and loneliness are recognized factor. And we come also to this conclusion from a number of studies. I could mention the superagers, the Grant study, but also the Amstel study. Myrra is probably very well aware that loneliness is increasing clinical dementia in later stage. A few studies that are directed in the same versus, like the Framingham study that highlighted that the loneliness is an independent risk factor for dementia. This is neurology stating that the risk in people which otherwise would not have other risk factor is increased in probability by 3 times by loneliness, or a general increase of 40%. All causes of dementia are increased apparently by loneliness. And this meta-analysis reaches even 60% of due to prolonged loneliness in the probability of having at the end dementia. Stroke and chronic heart diseases are other conditions that are affected by loneliness, which probably counts for an increase by 30% of this risk. Substance abuse that are very frequent. They are the second most risk factor after depression caused by loneliness. So substance abuse disorder or substance use disorder are very frequent in people who are lonely. And depression is estimated to be at least 18 times more frequent in people who are lonely than the general population. So the odds ratio are quite impressive. And
Diego,
clearly, yes?
excuse me, can you use the presentation mode?
Can I use the presentation?
Mode, the filter, so that we have a whole screen. It's
interrupted.
No, it has a side. Yes.
Slideshow mode.
Slideshow mode.
So Diego, at the bottom of the screen, over in the right-hand corner.
Yes.
At the bottom. Right, the next one next to it. Yep, that works.
Thank you. Great.
Yeah, sorry, so sorry.
No problem.
No. Great. Thank you.
Okay. So this is something that I said before about the bereaved people. So the difficulty in, but what I really wanted to point at your attention is the risk of suicide. These are data from the CDC, and 16.8% are the Americans above the age of 65. But the number of suicide is 22%. So there is a problem. And in Italy is even worse than that. We have 24% of the general population that are 65 and plus, but their number is 37% of all cases of suicide. So the problem of suicide, the problem of loneliness, the problem of the difficulties that these people encounter is really paramount. And let me also address your attention to this aspect that particularly males are affected. This is again the CDC, and please see the highest column here, which is the 85 and plus. It's nearly 20 times higher than the parallel column of females. So males are particularly exposed. There is a disproportion in numbers and the rates of suicide. And women are really super individuals, able to keep going with their networks, their capability for help seeking, which is much better than that of males. their capabilities in daily activities, etc., and having care of children and grandchildren even at very advanced age. And please see this study, which has been a fortunate study, very quoted. There is an Australian study. Different universities were cooperating, but these were psychological autopsies of people. And what was missing to those people was really the moral support of their family and the moral support of their friends. Was not the financial issues or other things. These people were felt really alone when they decided to take off their life. And even these studies were on telehelp and telecheck in Italy. They brought to the attention that people, if they were accompanied or cared by someone on a routinely based frequency, they succeeded in keeping going with less number of suicide than they expected. This is a very new study. Again, the variables on this model, it's the frequency of contact with the next of kin and the number of offspring still alive. So these factors are very important in people. Now, the conclusions are that basically research is needed in the area because we want to intervene, but we don't know how is effective or are effective our intervention. And this is because, as we have heard, loneliness has different causes, and individuals live their condition in a very different way. Also, times are changing, and in the past, maybe more than a century ago, loneliness was even a search condition, but today is not that case. And what we can do is today integrating into clinical care questions about, as David Conn pointed out, about the degree of loneliness and the condition that people are living in their life. And concluding with suicide, we need to remember that suicide in old age is not just the elimination of the self-elimination of an old individual, but is a message for younger individuals, because we need a determination, example of courage, and to nurture the sense of belonging of people. Otherwise, people will take a very bad conclusion in their life. This is my email and a website, and thank you for your attention.
Thank you very much for your impressive lecture, and especially for the impressive evidence you presented, and also for using the work of the Amsterdam group on loneliness, and Dr. Conn also. They are working on loneliness for approximately 30 to 40 years. So there is a lot, it's a great center of knowledge. And now the floor is for all who listened, and I already have several questions, and you are welcome to put more questions in the chat. The first question is for Dr. Conn. Always a pleasure listening to you. And the question is, what causes Parkinson's disease in lonely people?
Well, I think many of these are associations, and I think as Diego described, there are complexities in terms of these associations, intrinsic factors, extrinsic factors, and we have to think of a biopsychosocial understanding of these associations. So it doesn't mean a direct cause. I don't think you could say that that Parkinson's disease directly causes loneliness. It's strongly associated with loneliness, as are many chronic illnesses, and indeed the dementias. So I think there's a whole variety of factors. So if you're physically disabled and have trouble with mobility, you're much less likely to be able to get out unless you have good resources and supports, which can result obviously in isolation and loneliness. So I think it is multifactorial, and I mean there are these underlying theories as well that Diego also mentioned, such as the work of Casiopo thinking about the underlying neurobiology of loneliness and looking at factors like inflammation, and there are strong associations there as well. So I guess the bottom line is it's very complex, and these are strong associations. And I don't know, Diego, if you have any other thoughts about that question.
No, I think that the origins may vary from individuals to individuals, and there are clearly also factors that are very hard to modify, such as personality factors, for example. Introversion is a trait that you may inherit, for example, and it would be probably too ambitious to create different conditions, especially for men that have lived their entire life in that way. And so putting someone in the company of this type of person is not always a good solution, and it's very simplistic. And clearly we need to cooperate to create a great network on this topic, because it's really very important, and it's something that always risks to be banalized and to be considered as irrelevant, but is not.
Well, it's clear that it's a risk factor for several diseases, Parkinson's and dementia as well, and for mental health. So it's very important that we have these information on associations, but well, what to do about it? And the next question is about it. Loneliness is meant to be equivalent to smoking 2 packs of cigarettes a day. What are your comments on this?
Yeah, I've seen different numbers regarding the cigarettes. I've seen the number of 15 cigarettes. I haven't seen 2 packets a day, but I think either way, whatever the actual number is, I think as we've described today, there's just this extremely strong association between loneliness, isolation, and very negative health outcomes, including cardiovascular disease, cancer, you name it. So again, it's multifactorial, and I think it points to the fact that that we need national campaigns and programs that get the word out there. Now, when we did a survey of older adults in Canada as part of our work, a huge number said they were aware of the association between both physical and mental health issues and loneliness and isolation. So the word seems to be out there. But I think the big question is how do we help people to actually overcome their situation and provide the right resources? Yeah.
Well, I do have a question myself in between, because you mentioned the stigma related to loneliness. I think that if you want to address loneliness, you should consider that it's a stigma. So if you have a direct approach, so making a group of people to prevent loneliness, that might not help. So it's important to immediately be aware of the association between stigma and loneliness. So if we are looking for solutions, we really have to consider this. Well, this was my question in between. There is a question from the audience. One of the risk factors for loneliness I missed in both presentations is the low social skills. For example, how to start a casual conversation with unfamiliar people. And very important, how to listen to others instead of immediately telling your own story. Training such social skills may be also a very important option for interventions.
Yeah.
What about this?
Yeah, no, I agree 100%. That is correct. Some people are naturally good connectors, good communicators, and many individuals are not. Probably there's a difference between men and women. Again, Diego may want to comment on that, but women are better. But overall, on average, I have to say on average, that women for whatever reason. Historically and anthropologically, women are better connectors and communicators than men, and that could be a big factor as well. But yeah, that whole idea of teaching social skills, that's been, I think, prominent within the mental health world for decades. I think I agree completely that it is possible to educate and to teach this, and for some people it could be invaluable in terms of basic lessons in actually how to connect.
In the big preventive finger study, they use other activities in which they try to connect people, which might be one of the factors of the success of that interventions, for instance, exercise and so on. So there are many ways to indirectly address the problem of loneliness. Now, a question for Diego. What about the role of spirituality in protecting people against isolation? Has this been researched?
Well, I think this is a very important question. If you look on the past and looking at the Christianity, for example, in the past, people felt less lonely because the presence of God was everywhere, basically. God knew everything, and God knew also where to be when you needed him. Today, it's much more difficult to continue with people thinking that God is everywhere. Italian and Australian, and there are big differences between the two countries. But in Italy, for example, young people don't know how to enter a church anymore. So what to do? They don't know it. And so the having some form of spirituality can help. Having a credo probably would help even more. And even because you belong to a community, we meet in churches, we meet in location, you have some sharing of activities that are embedded with the religion you belong to. So the role of spirituality from this point of view, it's probably of great importance. Having other form of non-formal spirituality, not embedded with religion, probably have a different impact of loneliness, but they may help anyway. And I believe that loneliness in certain countries is very represented, and in other countries is much less represented. Curiously, in Italy, loneliness is unfortunately very, very strong, very, very widespread. And Italy is a country that has changed a lot in terms of religion in the last 50 years. So from being a very religious country to be a non-religious country, or virtually not any longer a religious country. And there is the Pope in Italy.
Yeah, and I just wanted to add that it is hard to compare rates of loneliness between different countries because of different methods used. But I've seen data suggesting that in Europe, Mediterranean countries report higher rates of loneliness than Central and Northern European. Well, and I'm surprised by that, actually. And I'm wondering, could that be that people in Mediterranean countries are just more willing to admit it and more in touch with their emotions? That's what I've thought. but I'd be interested in your thoughts, Diego.
It could be, actually, it could be. If you see at the comparison done, for example, with the young Girbel scale of loneliness between countries, you can see huge differences. And Italy is one of the worst. And in Italy, the National Institute of Statistics revealed that there are 30% of people that virtually don't know who lives in their condominium. They don't know where to knock a door that may have open to that in case of need, which is terrible because frequently they are living alone. And so not knowing where to go, which door to knock, it's quite frightening, quite disturbing.
Thank you. I want to go to another question, and there is some confusion about loneliness comparison between male and females. And the question is, Dr. David's presentation says females are more lonely. Is that correct?
Yeah, in most studies, females describe loneliness more often than men, but again, that could be related to, again, being in touch with your feelings and emotions and being willing to admit what's actually happening. And as Diego mentioned, I think that could be a big part of the issue with suicide in men. So I think we have to be careful about how we interpret those differences. But I think it's a problem, I think, very much for both men and women, in fact.
If I may, Myrra, I think it's a loneliness paradox in a way, because females live longer, so they have more opportunities, for example, to state something. And women are also more open about their feelings. They may be more extroverted regarding this capacity and their feelings. But males are those who kill themselves. And males, particularly at the advanced age, you have seen the scale of differences between females and males in the United States for people aged 85 plus. It's tremendous. So are those people more affected by depression? No, they are more affected by the incapacity to continue with living. So it's too hard for them. And and their culture in which they lived, they were educated, it's so different from the present day culture and education. They belong to a world that doesn't speak the same language anymore.
I have a last question, and I have to make choices, but the question is for David on the Canadian guidelines. What is the Canadian experience with social prescribing?
Social prescribing, yes. So it's really taking off in Canada. We now have a Canadian Institute for Social Prescribing, and their conference a couple of weeks ago was attended by many people. It was very successful. So actually, if you're really interested, it's worth going to their website. And there's a lot of pilot projects going on and increased funding. Actually, the foundation that supported our guidelines work, the Walton's Trust, has funded quite a lot of social prescribing projects in Canada. So we're quite fortunate to have that. And, I think I think that the outcomes, we need more research for sure, but it's very, very promising. And I think it's well worth the investment.
Thank you. Well, the good things of guidelines is that you have to come at the end with practical recommendations. And this is really one of them. Well, there are more questions, and I would like to ask both of you to answer these questions, and I would like to ask Christian to save the questions in the chat, allowing to answer these questions. We are coming to the end of the hour, and I would like very much to thank both presenters for their very interesting and many questions raising presentations. I think it's a very, very important topic, and we are still in the beginning on how to address it. And while there are so many years of research already, but it's time for action now, and to do it in a clever way, and that might be a bit of an indirect way. I also would like to thank the IPA organization for organizing this webinar. And I would like to thank the audience for their great questions and and showing that there are still more questions than answers on this topic. And lastly, I would like to ask you to fill in the evaluation forms. And what we do with the evaluation forms, there is always a question on which next topics you want. And many of our webinars are dedicated to the topics suggested by the audience. Thank you so much, and have a good day. And here in Europe, have a good evening. Thank you.
Thank you.
Thanks, everyone. Bye.